pulmonary disease as a result of chronic bronchitis. Well, how does it give you that chronic obstructive profile? Well, a number of different ways. First of all, the airways are very thick, narrowing the lumen. Secondly, the mucus production in the airway further narrows the lumen. So now you're breathing through these very narrow lumina. And as a result, the resistance to airflow is very high. That's going to reduce the FEV1. So this would be classified as a type of obstructive pulmonary disease. It develops very slowly, and so we call it a chronic obstructive pulmonary disease. Let's take a look at some of the architectural changes that occur to the respiratory wall as a result of this chronic inflammation. First, let's take a look at a structure section through normal wall. Okay, here's a comparison of the two walls. The first thing you notice is that the thickness of the normal wall is a lot thinner than what you got here in chronic bronchitis. The chronic bronchitis wall is very thick. The normal wall is very thin. Okay, here's the luminal. This is the lumen of the airway here. You can see the wall of the airway over here. First layer is the epithelium. You can see it consists of a normal pseudostratified ciliated type of epithelium. Everything looks good, sits in the basement membrane, and below that you have what we call the lamina propria. Lamina propria is over here. You can see some inflammatory cells in lamina propria. That's part of normal physiologic inflammation. You got to have that there. So you have sentinel cells constantly patrolling that part of the respiratory epithelium exposed to the atmosphere. And these sentinel cells are just standing guard here, not really do anything unless they have some sort of invader that they have to attack. Below that, you can see the muscular mucosa. It's very thin. You can hardly see it here, but it's very thin. Okay. Below the muscular mucosa, we have the submucosa. The submucosa, it consists of lots of little submucosal glands. Look at the submucosal glands. You can see they're kind of mucoserous types of glands. They have characteristic features of both serous as well as mucus glands. These glands produce a secretion that will add to the different layers of mucus that you have in the respiratory tract, again, all of which is designed to trap adulterants. The cilia of the pseudostratified cells will move all this material up to the organs where one swallows it. Beyond that, you have the kind of structural cartilage right here that keeps the airway nice and patent, nice and sturdy. Okay, everything looks good over here. Chronic bronchitis, very different architecture. First thing you notice, you get the lumen here, you got the epithelium over here. Something wrong with that epithelium. Take a look at that epithelium, we'll zoom in. There's the lumen, there's the epithelium. What's wrong with that epithelium? Squamous. That's a metaplastic squamous epithelium. It's actually a stratified squamous epithelium. That's not supposed to be there. It's supposed to be a pseudostratified ciliated epithelium. Why do we have a stratified squamous epithelium? Chronic bronchitis, chronic inflammation. The ciliated cells are very delicate. They'll degenerate under those conditions of inflammation. And so because they're constantly degenerating, the body's just going to replace them with something tougher. They can tolerate the inflammatory conditions, and that's a stratified squamous epithelium. So you have the stratified squamous epithelium there that replaces the pseudostratified ciliated cells that are very delicate. Okay. That's the first problem we see here. Is we see squamous metaplasia right up there. Below that, you can see the lamina propria. Lamina propria. Ooh, it's a lot thicker. Okay, there's the lamina propria over here. There's the lamina propria over here. Why is it thicker? Look at all these spaces over here. That's all edema. That's edema. Those white spaces. This is a lot of edema. Look at the muscularis mucosa here. Geez, you can barely see the muscularis mucosa over here. Maybe a little piece of it there. Look at the muscularis mucosa and how thick that is. It's thickened because of chronicity of disease. Chronic inflammation causes it to become a lot thicker. Below that, we have the, what's this layer? Below the mucosa, that's the submucosa. It's filled with lots of glandular structure, submucosal glands. There's an increase in the thickness of submucosal glands. And below that, of course, we have the cartilage. We have several layers that have increased in thickness as a result of the chronicity of disease. And that, of course, overall has expanded the width of the entire airway wall. And that increase in thickness in the airway wall has occurred at the expense of the luminal diameter. And of course, that adds to the resistance to airflow through the lungs. That causes a drop in the FEV1. Now, we do have a way of histologically assessing the thickness of the airway. We calculate something called the Reed index, And the Reed index is just a calculated variable that helps us diagnose chronic bronchitis, at least on a histologic level. The Reed index compares the thickness of the submucosal layer to the thickness of the mucosa and submucosa. So we're comparing the thickness of the submucosal layer, submucosal glands, so the thickness of the mucosa and submucosa. We take a look at that ratio. Normally the ratio is something like 0.3, something like that. Now this is about a third, maybe, the overall thickness. Over here, you can see there's an increase in thickness of the submucosal glands, almost to the point where it looks like the Reed index is close to 0.5. Comparing this thickness to this thickness here, okay, almost 0.5. That's called the Reed index. It's one of the histologic methods of evaluating a specimen for chronic bronchitis. Now, there's a big increase in thickness of the submucosal gland. Okay, and we compare that, we calculate the ratio that's called the Reed index. Okay, and Reed index is elevated in chronic bronchitis. Okay, so we got a lot of different structural changes that occur, okay, in chronic bronchitis. Any questions on that? Okay, a few other things we want to know. Again, I said cough, hypersecretion of mucus. Again, people are coughing up mucus. Mucus can be of different colors depending upon whether there is some sort of co-infection or not. Risk factors for developing chronic bronchitis: if you're inhaling anything that's irritating, you're smoking. Sulfur dioxide is a big offender. Usually you encounter it more industrialized areas. Again, it's a byproduct of manufacturing. Inhale that, it turns into an acid and irritates. Okay, again, presentation: mucus, hypersecreted, that's a defining clinical feature, and you're coughing with the cough itself is productive. Okay, microscopically, we've got all kinds of inflammatory cells, but again, eosinophils are absent. Okay, goblet cells, which produce a lot of mucus, sometimes increase in number. You'll have squamous metaplasia of the airways. That's because of the irritation that you have. Okay. Sometimes the irritation gets to the point where not only have metaplastic changes, but you have dysplastic changes. There's increase in the risk for developing some sort of a squamous carcinoma, squamous cell carcinoma. Okay. Any questions on that? Next thing we want to take a look at, another chronic obstructive pulmonary disease. Bronchiectasis. Bronchiectasis. What does that word mean to you? Ectatic, you know what ectatic means? Ectatic. Telangiectasias means dilated. So bronchoectasia, bronchiectasis, that's a condition where the airways dilate. Okay, ectatic means dilate. Of course, bronchi refers to the airways. This is a condition where certain infections get into the airways and they destroy the muscular layer that controls the caliber of the airways. When you destroy this muscular layer that controls the caliber of the airways, nothing restrains the diameter of the airway. Over time, the airways remodel into very large airways that have extremely thick walls. This is what we call bronchiectasis. Bronchiectasis is generally caused by certain types of infections we call necrotizing infections. These necrotizing infections specifically cause the destruction of the muscle that controls the caliber of the airway, resulting in these airways being unrestrained, and over time, with a lot of airflow, mechanical forces that cause it to assume a new dilated morphology. Let's take a look at this. Here's an example of a normal airway. There's the lumen of the airway, there's the wall, of course. Constricting the airway wall diameter, we have these rings of smooth muscle, okay? Generally controls the caliber of the airway. They relax, the airway gets bigger, dilates, they constrict, the airway, of course, gets smaller. Sometimes specific types of infections like staph or Klebsiella or even Mycobacterium TB getting here destroy this smooth muscle there that controls the caliber of the airway. Without that muscle to constrain the dimensions of the airway over time, the airway just dilates by remodeling. The airway gets big and it develops this very thick-walled architecture. This is called bronchiectasis. Typically, as a result of bronchiectasis, the airways become flimsy, okay? They collapse. Sometimes, as a result of the infection itself, some of these airways will actually stricture in certain areas. There can be lots of mucus production. And so a person with bronchiectasis has these very large, thick-walled, dilated airways. During an active infection, they'll be coughing out sputum. Usually the sputum will have a lot of blood in it. The sputum will be foul-smelling. It'll be fetid. And that's a foul word for foul-smelling, fetid. Okay, let's take a look at some of this damage that's done by these different organisms. Okay, here's a section through one of these airways. Again, you can see the lumen of the airway. There's the airway wall architecture, showing you the different layers. We've got the epithelium, lamina propria, and there is the muscle layer that controls the caliber of the airway. During these necrotizing infections, that's the muscle layer that's destroyed. Again, common genera would be Klebsiella, staph, Mycobacterium, especially Mycobacterium TB. Okay, all of those can destroy this smooth muscle layer, resulting in what we call a necrotizing infection. Once that muscle layer is destroyed, there's nothing constraining the dimensions of the airway, and people develop these very large, thick-walled airways. You can see it here. Here is a section through lungs demonstrating bronchiectasis. Again, you can see the apices of the lung here, base of the lung here. Cut surface of the lung is being shown. You can see a normal cut surface of the lung down here. It has nice kind of granular architecture to it. That looks good. Up in the apices of the lungs, you can see these large cyst-like lesions. See them all through here, all through the apices of the lungs. Those actually aren't cysts. Those are airways. Look at the diameter of the airway. And look at the airway wall thickness. Okay, this is bronchiectasis. Airway ectasis, meaning dilated, bronchiectasis. And some of these airways are very flimsy. Other areas might be strictured due to inflammation. And all of these together combined create an increase in airway resistance. So a person inhales, they exhale, they have trouble exhaling, and that's going to reduce the FEV1. And so bronchiectasis falls in the category of a chronic obstructive airway disease. Okay, let's take a look at the radiographic appearance of bronchiectasis. You can see these dilated airways with thick walls on a radiograph. They appear in different shadows, depending upon how you're looking at them. Sometimes you're looking in the longitudinal profile. Let's take a look. Here's a chest radiograph. There's cardiac silhouette. We're looking at the left lung field. We see vascular markings. And then we see these two lines over here. Two lines that are parallel to each other, the radiodense lines. Those are the shadows of the airway wall. They look like they're two parallel lines. So it looks like a tram track. So people call this tram track. That's a tram track. just the shadows of the airway walls that are superimposed at the film. Sometimes you can see one of these airways in kind of cross section. You kind of see the airway wall very thick. It kind of makes a circular shadow. There's an example of one. There's the cardiac silhouette, the diaphragm here. Look at that. That house, radio dense kind of circular outline. That is an en face profile of one of those dilated airways with a thickened wall. This appearance is sometimes called cuffing. Cuffing. Airway is really, really thick. That's cuffing. Okay, there's another finding you typically see in people with really severe bronchiectasis. It's not a finding that is specific to bronchiectasis, but rather you can see it in all kinds of pulmonary diseases of different degrees. It's clubbing of the fingers. Clubbing of the fingers is non-specific finding. You very often see it in very severe types of pulmonary diseases, particularly in bronchiectasis and things like cystic fibrosis, okay, that results in a lot of pulmonary disease. The clubbing of the fingers, of course, presents with these kind of dilated fingertips, kind of bulging fingertips that you see here. They kind of make it look like clubs. Okay? Now, there are different degrees of clubbing. This happens to be a very severe example of clubbing of the fingers. Very often, this is linked to some sort of pulmonary disease of any kind. Pulmonary disease is non-specific finding. If you want to really assess carefully whether someone has clubbing or not, ask them to put their two index fingers together like this. If you do that, you see a big space between the base of the nail beds. That's probably clubbing. Okay, so you can really assess the degree of clubbing that way. Any questions on that? Okay. A couple of risk factors for bronchiectasis. Again, we got these different recurrent infections, staph, Klebsiella, and TB. Sometimes these hereditary conditions like cystic fibrosis can cause an awful degree of bronchiectasis. Anything that really occludes the airway can promote infections that cause bronchiectasis. Again, we talked about the presentation. These different infections are episodic. When someone does have an episode of an infection, they develop a severe cough productive of very foul-smelling sputum, call that fetid sputum. And of course, you can see radiographic evidence of airway dilation, namely tram tracking and cuffing. Any questions on that? Okay.
You said obstruction. What did you mean by that?
The airway is blocked. All right. Well, we mentioned cystic fibrosis, so let's take a moment to talk about cystic fibrosis. Okay. Cystic fibrosis is a genetically based disease. It is a disease which, in part, causes some complications in the pulmonary system, often resulting in many different changes in the lung, including those which cause things like chronic obstructive pulmonary spirometric profiles. The problem is with a gene located on chromosome 7. The gene encodes for an anion channel, generally that conducts chloride ions. The protein channel is called the cystic fibrosis transmembrane light regulator, or the CFTR for short. It's an anion channel, and it's encoded for by the CFTR gene located on chromosome 7. Now, the channel transfers chloride ions across membranes, and these chloride ions are very important in regulating various aqueous phase volumes. It's very important in regulating hydration of certain types of secretions. If it doesn't work properly, if it's not conducting chloride properly, then it affects the secretions that are produced in the airway, causing the airway to have very viscid types of secretions. And these secretions become inspissated in the airways. They form concretions, they become solid. And once this forms, it's very difficult for that mucus to clear. The mucus becomes contaminated full of different microbes. It can't be clear. And so people with cystic fibrosis develop a lot of different infections, including things like necrotizing infections that lead to bronchiectasis. And then they have a whole host of other problems, not just in their lungs, but in their pancreas. Same type of thing occurs in the pancreas. The secretions of the pancreas become very viscid, form concretions, resulting in scarring of the pancreas. And in the end, the pancreas becomes very cystic and fibrotic. And that's where the name cystic fibrosis comes from. It's actually the appearance of the pancreas, not so much the lungs, but the appearance of the pancreas. Well, this is a problem throughout various bodily fluids. You can't conduct chloride properly. You can't regulate volumes. You can't regulate hydration of certain secretions, and they tend to become inspissated and dry out. Now, we're going to talk a little more about the channel, but let's just see typically how this disease is transmitted. It is classified as an autosomal recessive disease, which means that in order to develop the disease phenotype, you have to inherit two mutations, one from the maternal parent, one from the paternal parent. Now, for every protein that you encode for in your body, you have two genes for it. One comes from mom, one comes from dad. In order for the disease to develop, you have to completely take out the cystic fibrosis transmembrane regulator. You have to take out both genes that encode for it. And so to develop the disease, you have to inherit a mutant gene or allele from mom and a mutant gene or allele from dad. And once you have these two mutant genes, you can no longer produce a normal CFTR, and that's when you typically develop the disease phenotype. All right. Let's take a look and see how the disease is typically transmitted.
Sorry, so when you say this, like CFTR is effective, which way is the line not going?
It doesn't conduct. I'm actually going to show that it affects different departments differently.
Okay.
But the CFTR generally does not conduct chloride.
And then it gets stuck on one side? Is it on the
I'm
weaker
actually
side?
going to show you that depending upon what organ tissue we're talking about. All right, so let's take a look at typically how this is transmitted to progeny. Usually, you have two parents, both of whom are carriers. They don't have the disease, but one of the two genes that they have encoding for CFTR is defective. Now, if they just have one gene that's mutant, but have another good gene, this is first of flying. You want to see the lecture? In any case, if you have one good gene, no problem. You can still encode for a CFTR that works, and that's what happens in the carriers. They have one defective gene, but the other gene's just fine, so they're fine. Okay, however, if they produce children, okay, they're going to have to sort these genes during meiosis. There are a number of different ways that these genes can sort, and during the process of forming the zygote, they can come together in kind of different combinations. We should generally show these combinations using a Punnett square like this. So let's take a look at this. Here are the two genes of the mother represented with a capital C and a lowercase c. The capital C is normal, the lowercase c is the defective gene. Okay, these things are going to sort and separate. Father over here, also a carrier, has a good gene and a bad gene. Come together. There are four possibilities. Okay, both mom and dad can donate a normal gene. If the child is two normal genes, he's not even a carrier. He's fine. Dad can donate a mutant gene. Mom can donate a normal gene, and the product here is a carrier. The child is, again, phenotypically normal, but the child's a carrier. Mom can donate a mutant gene. Dad can donate a normal gene. And again, you have a child that is a carrier. There's only one possible combination left. Dad can donate a mutant gene and mom can donate a mutant gene, making this child receive two mutant genes. Receive two mutant genes, this child is going to display the disease phenotype. Okay, 75% of the time, the child is going to be normal, but 25% of the time, the child will have cystic fibrosis and have the disease phenotype. Okay. Now, because you need two genes to manifest the disease, we call this a recessive disorder. You have to have two genes to manifest the disease. Because the gene is located in one of the autosomal chromosomes, chromosome number 7, we call this a autosomal recessive disorder. Okay, 25% of the time between two carrier parents, the child is going to be diseased, going to have the disease phenotype. Let's take a closer look at this. Here's an example of a karyotype showing the different chromosomes. Okay, we have 23 chromosomal pairs, a total of 46 chromosomes in our diploid cells, which is most of our somatic cells. Most of our somatic cells are diploid. They're generally listed here from largest chromosome to smallest chromosome. Largest chromosome is 1, smallest chromosome is 22, and then of course we have the sex chromosome pairs here. The first 22 chromosomal pairs are called autosomes. The last pair is called the sex chromosome. Okay, and if you take a look at this karyotype, you'll notice this person has two X chromosomes, meaning, of course, they're generally genotypic female. We expect them to phenotypically be a female as well. This person would be described as being 46XX, a normal genotypic female. Now, the problem with cystic fibrosis is with a gene on chromosome 7. Okay, chromosome 7's here. Both of these chromosomes are normal. However, in a carrier, one of the chromosomes has a defect in the CFTR gene. Okay, here's an example karyotype. There's a little defect in the chromosome 7 where the CFTR is encoded. Okay, this person's a carrier. Okay, one normal gene, one mutant gene. Okay, no problem here. Normal phenotype, just like this individual. However, if a person inherits two mutants, CFTR genes on chromosome 7, like this person did, well, this person has both of these mutants, both of these genes mutated, the person's going to develop a disease phenotype. They got the disease phenotype, CC, okay, lowercase cc. So we call this a autosomal recessive disorder. The problem's on one of the autosomal chromosomes, and you need two genes to express the disease phenotype. All right, let's take a look at the problem. Again, chromosome 7, long arm of chromosome 7 is where you find the CFTR gene. It codes for a chloride transporter, chloride channel. Okay, it's actually an anion channel, but preferentially conducts chloride ions. This is what the channel looks like. Composed of a number of different domains. Okay, there's the phospholipid bilayer. There's the pore right there, through which pass the chloride ions. You've got a number of different domains aside from the pore. You've got these nucleotide binding folds, and then you've got a regulatory domain. This regulatory domain will turn the channel on and off by blocking it or opening it. Okay, this is what a depiction of a normal CFTR product, CFTR protein, would look like. Now, when it's conducting chloride channels, the body can regulate fluid volumes, can regulate hydration and secretions. But when it's not working, when it isn't conducting chloride ions, things become problematic. Let's take a look at what happens in the pulmonary system. So here's a depiction of the airway. We've got the airway movement here. We've got some of the respiratory epithelium over here. We've got some goblet cells producing mucus, layering them on the cells. And then we've got these other cells right there. This would be like one of the pseudostratified ciliated cells. Normally, pseudostratified ciliated cells encode for this chloride channel. Okay, chloride ions will be conducted from the cell into the mucus.
Sorry.
Okay, chloride goes into the mucus. All right, well, it's negatively charged. When it goes in there, it's going to pull with it a cation, sodium. Sodium gets into the mucus. Now you got sodium chloride in the mucus. Now it's osmotically active. It's going to pull with it a lot of fluid. And so now the mucus has a lot of fluid in it. So now the mucus is nice and fluidic, easy to move in the airway. Move that up, swallow it, gets it out of the way when it gets adulterated. That's the way things are supposed to work. Cystic fibrosis, that channel does not conduct chloride ions. See what happens down here. Okay, again, we got our mucus. The chloride channel isn't conducting ions there. Sodium's not going to be. No sodium chloride in the mucus, no sodium chloride, water doesn't follow. The mucus is not hydrated. Not hydrated, it dries out, and it becomes stagnant. And this stagnant mucus is infected with all kinds of things. It stays there. And people with cystic fibrosis very early on start developing a lot of pulmonary infections, some of which destroy that smooth muscle layer that controls the caliber of the airway, that develop bronchiectasis and other pulmonary problems. And so very early on, people with cystic fibrosis are developing numerous problems with their pulmonary system as a result of simply not controlling the passage of fluids across an epithelium. Something similar happens in the pancreas. Pancreatic secretions get inspissated like this, and it causes degeneration of the pancreas, making it cystic and scarred, cystic and fibrotic, hence the name cystic fibrosis. Okay. Other problems develop with salt in the sweat. Okay. We sweat, there's a lot of salt in that sweat, and some of that salt is resorbed. Okay. When we sweat, a lot of the salt is resorbed through a process involving the CFTR protein, CFTR transporter. People with cystic fibrosis, they don't resorb the salt. And so the sweat has excessive amounts of salt, and a lot of salt gets deposited on the skin. And in the past, sometimes that was the clue to the diagnosis. The mother of someone, mother of a child with cystic fibrosis, would complain that the child tastes very salty. And that's because when the child sweats, none of the salt would be resorbed. And when the mother kissed the child, they would say, that tastes really salty. Okay. And that's how we get the clue. Maybe there's cystic fibrosis here. In the past, cystic fibrosis was called, guess what?
Cannibalism.
Cannibalism syndrome. Salty baby syndrome. Salty baby syndrome. And that's the story of salty baby syndrome.
It's sweet to go with it. Salty and sweet.
Maybe diabetes. Well, that's a diabetes.
There you go. Sprinkle a little diabetes on
Sweet,
there.
salty. Sweet, salty. Okay, let's take a look.
Cystic fibrosis. Put a little diabetes in it. It's a good baby.
A lot of different mutations take out the function of the CFTR, but there is one very common mutation. It's very severe. It causes severe form of cystic fibrosis. The mutation is called the delta F508 mutation. This delta F508 mutation results in a deletion of a phenylalanine amino acid in the 508th amino acid position from the N-terminus. So count amino acids from the N-terminus. Okay, 508 is supposed to be a phenylalanine, but in certain mutations, the phenylalanine is missing. We call it a delta. Delta stands for deletion. F for phenylalanine. 508 stands for the normal position it's supposed to be in. The delta F508 mutation is one of the more common severe mutations in cystic fibrosis. And there are all kinds of mutations. There are thousands of mutations that can cause cystic fibrosis. But this is one of the more common severe ones. Okay, let's take a look and see how this works. We're looking at a normal sequence of DNA in the CFTR gene. Let's see, we got these aggregates of trinucleotides that correspond to various amino acids they encode for. Okay. All right, so we have in the normal DNA a sequence ATC that encodes for isoleucine, ATC, another isoleucine, TTT phenylalanine, GGT glycine, and GTT of valine. Okay, everything looks good there. Sometimes a trinucleotide sequence is deleted. This one right in here. We drop the C, the T, and the T. Now, when ribosomes are reading an RNA sequence, they're reading successive trinucleotide sequences in the RNA. There's nothing separating the trinucleotide sequences that encode for codons and corresponding amino acids. The ribosome just reads trinucleotide sequence in series. So every group of 3 nucleotides is read. Well, when the ribosome reads the corresponding messenger RNA to this DNA, it's reading things like ATC, varinucleotide isoleucine. But the next trinucleotide sequence it reads is a combination of 2 codons, ATT from this one, AT from this one, NT from this one. So it reads ATT, which encodes for an isoleucine. Well, it's actually happened to be normal too. But then it reads a GGT, puts a glycine in. Glycine over here. Where's the phenylalanine? It missed the phenylalanine. That's a phenylalanine deletion. That's why we call it delta F 508 mutation. Now, this deletion of the phenylalanine robs the channel of its conductance. It won't open. It's constantly closed. Okay, and there doesn't seem to be a very easy way to get it back open again, at least pharmacologically. Okay, people with cystic fibrosis have numerous problems, depending upon the severity of the disease. Okay, here are some of them. A lot of sinus infections. Children present with sinus infections. Okay. 90% have problems with their pancreas. They're eventually going to develop pancreatic insufficiency, which will cause malabsorption. They don't have a lot of pancreatic enzymes, of course, because the pancreas is scarred. That's what leads to malabsorption. Usually they'll present with steatorrhea. That's a type of diarrhea with a lot of fat content. The pancreas isn't making enzymes, including lipases. You can't absorb fat. And so a lot of fat remains in the stool, and that's passed. We call that fatty stool or steatorrhea. That's how that presents. And of course, they have numerous problems with their airways. Chronic bronchitis, bronchiectasis, okay? Numerous problems with the airways. Okay. Another problem that developed, we don't see it often, maybe 1 in 10 people with cystic fibrosis, but when we see it, it's almost pathognomonic for cystic fibrosis. Meconium ileus, you know what that is? Meconium ileus? Yeah, meconium ileus, it refers to, well, you know what meconium is? It's that kind of greenish material that an infant will pass initially. When they're born, they'll pass that meconium. Okay, supposed to pass that meconium. Sometimes they don't pass that meconium. That meconium is inspissated and thick, and they can't pass it and obstructs the bowel. We call that meconium ileus. And generally, we don't see it very often, even in people with cystic fibrosis. But when it does present, the first thing on our differential is going to be cystic fibrosis. We see meconium ileus. Liver complications, not the most common problem, but we do see those. Men usually are sterile. They have usually partially sterile. They have azoospermia, which means just immotile or mobile sperm. There is even a reduction in women's fertility, probably a 30% reduction in female fertility as well. Okay. Any questions on that? Okay.
I have a question. So the delta 508 was what caused the CFTR gene problem?
That's one of the many mutations that can cause cystic fibrosis.
And then after the delta 5 is called phenotype, is out there means for the phenotype or just for the phenylalanine?
The F is standing for phenyl. Phenotype is physical appearance, as opposed to say genotype, the gene makeup. For example, a person who has this chromosomal composition, actually, it should be a comp there.
46XY. What's their phenotype, male or female? All right, you would expect them to be male, but there are some genetic recombinations that could cause this person, 46XY, to actually be phenotypic female, even though they're genotypically male. So we make the distinction that way. Okay. All right, so if I asked you the definition of malignant hypertension, what would you tell me? What are you laughing? I'm just asking. What's the definition of malignant hypertension? Someone who's got blood pressure in excess of 200 over 120. Right, either one. Okay. And what do you call a platelet? What's the condition called when platelets don't work as a result of aspirin? Thrombocytopathy.
Write that down.
Get that big egg recording.
Good egg.
Am I still in your way?
Not moving, you okay.
Okay, remember, we got a review at 2:30 today.
Give us one more.
Give you one more.
Yeah.
Scott, just make sure we have-
What? I'm going to the review, dude.
Okay,
Give us a really, really hard one.
a really hard one.
Yeah. Something, yeah, exactly.
Yeah, something that's on the test, but it's really hard.
That none of us would get.
Okay,
So we have.
so seborrheic keratosis.
What about it? That's nerve.
Yeah.
That's that's stuck on the gum lesion.
Oh, that's good. That's exactly good. That's a good description. It appears as like gum stuck on the skin.
Yeah.
Okay.
Gross.
Gross. Usually you see it in older individuals. Okay, we'll see you at 2:30 then.